Welcome to the Deep Dive,
Yeah.
the place where we try to make sense of complex physiological processes, turn them into essential knowledge for you. Today we're diving into, well, the circulatory system's delicate balance, hemodynamics, and fluid control.
It's fundamental, isn't it? Blood circulation.
Absolutely. It's the engine, really, delivering oxygen, nutrients, whisking away waste that keeps our tissues healthy.
But it's fragile, that infrastructure.
It is, and when flow gets disrupted, that's when we see pathology. So our mission today is to cut through some potential confusion. We're looking at two disorders that both involve increased blood volume in tissues, hyperemia and congestion.
Right. And they sound similar, maybe even like synonyms sometimes.
They do, but understanding the difference is just fundamental. It's key for figuring out what's actually gone wrong.
And that difference, that's the real aha moment we want you to take away. It's not just that there's extra blood.
No.
No, it's how. How did that volume increase? Was it an active process, the body deliberately opening the gates? Or was it passive, like a blockage? A failure in the system, maybe a faulty pump or a clogged drain.
Active versus passive.
Exactly. And that distinction tells you so much about the cause. Is it benign? Is it necessary? Or is it, potentially really serious?
And we're going to explore the downstream effects, too.
Yeah.
Because these processes create some really memorable visual cues, don't they?
Oh, definitely. Very distinct pathologies.
Like why tissues turn bright red in one case versus a kind of dusky blue red in the other.
Erythema versus cyanosis.
And even how chronic backup can create this amazing pattern in the liver. The nutmeg liver.
That's the one. Quite striking visually.
Okay, let's get into it. Let's unpack this. Let's start with hyperemia. Now, you said this one is, well, maybe the good guy in some ways, or at least necessary.
You could sort of think of it like that sometimes. If congestion is blockage, hyperemia is more about intensity. It's an active response.
Active. Okay. So what's the mechanism, this rush of blood you mentioned?
It really is a rush. Hyperemia is basically the vascular system actively deciding to increase flow to a specific area.
How does it do that?
It does it through arteriolar dilation. So think of arterioles as little gates controlling blood flow into the tissue capillaries.
Right.
In hyperemia, those gates swing wide open. It's an intentional increase in the rate of blood flow, the perfusion, into that capillary bed.
And what tells the gates to open?
It's tightly regulated. It can be neurogenic stimuli, the nervous system sending a signal.
Okay.
Or more often, it's local chemical signals. Like if a tissue is working really hard, its metabolic activity goes up.
Makes sense.
It produces metabolites, think lactate, potassium ions, adenosine, or maybe the tissue just senses a drop in oxygen or pH changes. These signals tell the smooth muscle in the arterial walls to relax.
So the vessel widens.
Exactly. The diameter increases. It's the tissue itself demanding more supply, an active demand-driven process.
Okay, so where do we typically see this happening? You mentioned contexts, physiological, and maybe inflammatory.
That's right. Two main scenarios. Physiologically, think about exercise.
Right, like my legs when I'm running.
Perfect example. Those muscles need way more oxygen, more fuel, than when you're resting.
So the gates open wide?
Precisely. Local autoregulation kicks in to meet that immediate, very active demand. The increased flow delivers the goods and clears out the waste products faster.
How efficient.
Very. As soon as the muscle starts burning fuel, local signals like oxygen levels dropping trigger the release of vasodilators. Nitric oxide is a big one.
From the endothelium, the lining of the vessel.
Yes, from the endothelial cells. Nitric oxide tells the surrounding smooth muscle, relax. Ensures supply keeps up with or even exceeds demand. That's your classic physiological hyperemia.
Okay, and the other context, inflammation.
Yes, pathological hyperemia. It's a absolutely essential part of acute inflammation.
Like if I get a splinter or an infection.
So tissue is damaged. The body needs to send in the troops, its defense mechanisms. So chemical mediators released right there at the site, histamine, prostaglandins, they cause a really strong arteriolar dilation.
Wider gates again.
Much wider, dramatically increases blood flow. This lets immune cells like neutrophils and macrophages plus plasma proteins rush into the area. It's an active defense.
And this active rush, it changes the color.
Right.
You mentioned visual cues.
Absolutely. Because the mechanism is increased inflow through the arteries, The blood arriving is fresh from the lungs, highly oxygenated.
So it's bright red blood.
Exactly. And that makes the tissue itself look bright red. That visible reddening has a name, erythema.
Erythema.
And seeing erythema clinically tells you the underlying vascular process is active. It's supply side.
Okay, now let's flip the coin. Let's talk congestion. This sounds more like the bad guy, if you will. You called it a passive process.
It is. If hyperemia was about opening the supply gates, congestion is the opposite. It's about blockage or impairment on the outflow side.
So not inflow problems, but drainage problems.
Precisely. Congestion is a passive condition. It results from reduced venous drainage. Blood can't get out of the tissue effectively.
So it backs up.
It backs up.
Yeah.
Like you said, it's not the faucet turned on too high, like hyperemia. It's a clogged drain.
And this clogged drain, can it affect the whole system or just one part?
Both. We usually think about it in two ways. First, there's systemic congestion. This is widespread.
Affecting the whole body.
Pretty much. The classic example is congestive heart failure. If the heart itself, the main pump, isn't ejecting blood properly,
Then the pressure builds up backward.
exactly, backs up through the entire venous system. So you get congestion everywhere, lungs, liver, legs, you name it. It's a system-wide plumbing failure.
Wow. Okay, and the other type?
The other is localized congestion. This is confined, just affecting one specific area.
What causes that?
Typically, an isolated blockage in a vein. The most common thing we think of is a deep venous thrombosis, a DVT.
A blood clot in a leg vein, for example.
Yeah, exactly. A clot forms, physically blocks the outflow from the capillary beds downstream, or rather upstream from the heart's perspective, but downstream anatomically. So the congestion is only in that limb below the clot.
Got it. Now, the color change here is crucial, isn't it? You said hyperemia gives you red, erythema. Congestion is different.
Very different. Congested tissues take on this abnormal blue-red color. Clinically, we call this cyanosis.
Cyanosis, why blue-red?
It's the ultimate proof the blood is stagnant, just sitting there, because the venous drainage is blocked or slowed way down.
The blood lingers in the capillaries.
Right. It lingers, and the surrounding tissues keep extracting oxygen from it. So the blood that accumulates has used up its oxygen load. It's full of deoxygenated hemoglobin.
And deoxygenated hemoglobin looks different.
It looks darker, kind of bluish purple. It absorbs light differently. That's what gives the tissue that characteristic dusky blue-red look. Cyanosis tells you immediately the problem isn't a rush of fresh oxygenated blood. It's pooling of old deoxygenated blood, a drainage failure.
Okay, so the color change is a big clue.
Yeah.
But you mentioned the long-term consequences of this passive backup congestion are much more serious, more destructive than, say, temporary hyperemia.
Oh, absolutely. Chronic congestion causes real structural damage over time.
What are the main problems?
Well, the fundamental issue comes from that sluggish flow. The first big consequence is chronic hypoxia, low oxygen.
Because the blood isn't moving efficiently.
Exactly. Efficient gas exchange breaks down. The tissues are essentially starved of oxygen because, one, the high back pressure prevents fresh oxygenated blood from getting in easily, and two, the blood that is there has already given up its oxygen.
It's like the tissue is being suffocated by the pressure.
That's a good way to put it. Think of a swamp versus a clear running stream. The swamp has water, sure, but it's stagnant, low oxygen, can't support much life.
Right.
In long-standing chronic passive congestion, this constant lack of oxygen leads to ischemic tissue injury.
Ischemia meaning lack of blood flow, or in this case, lack of oxygen from poor flow.
Lack of oxygen specifically causing cell damage and death. And the body's natural response to ongoing injury and cell death, it tries to patch it up.
Scar tissue.
Yes, scarring, fibrosis. The tissue becomes scarred as it tries, often poorly, to repair the damage from chronic hypoxia.
Okay, so chronic hypoxia leading to cell injury and scarring. What else?
Well, that constant high pressure, remember, that's the definition of venous backup. It directly causes another problem, capillary rupture.
The tiny blood vessels burst.
They do. Capillaries have incredibly thin, delicate walls. They're designed for low-pressure exchange, not for handling the kind of hydrostatic pressure you get in congestion.
So they just malpop.
Essentially, yes, they rupture. This leads to tiny little bleeds scattered throughout the tissue. We call them small hemorrhagic foci.
Little spots of bleeding. And this is where those macrophages come in, right? The cleanup crew.
Exactly. This rupture is what gives pathologists the smoking gun, the microscopic proof that chronic congestion has been happening.
How so?
When red blood cells leak out of the capillaries into the tissue space, they're not supposed to be there. So macrophages rush in.
To clean up the mess.
Right. They engulf these leaked red cells, that's phagocytosis, and then they break down the hemoglobin inside.
Hemoglobin has iron.
Correct. And when the macrophage breaks down hemoglobin, it stores the iron as this granular kind of golden yellow or brownish pigment called hemosiderin.
Hemosiderin, like rust almost.
Sort of, yeah, it's iron storage.
Mm.
So when a pathologist looks at a biopsy from chronically congested tissue under the microscope,
They're looking for these macrophages.
they're looking for macrophages absolutely stuffed, packed full of this brown hemosiderin pigment. These hemosiderin-laden macrophages are a dead giveaway. They confirm there's been chronic passive congestion causing repeated microhemorrhages over time. Tangible proof of damage.
Wow. Okay. And there was one more consequence related to the pressure itself. Swelling.
Yes, absolutely. Edema. Remember that hydrostatic pressure in the congested capillaries and veins?
Right. The physical force pushing fluid out.
Well, in congestion, that pressure skyrockets. It completely overwhelms the forces that normally keep fluid inside the vessels, like plasma protein concentration.
So fluid leaks out.
Loads of it. Water, electrolytes, even some small proteins get pushed out of the vasculature into the surrounding interstitial tissue spaces.
And that's edema.
That's edema. Noticeable fluid accumulation, swelling. It's why congestion so reliably leads to edema in the affected organ or limb. The pressure physically forces fluid out.
Okay, to really see how destructive this chronic backup is, you said we need to look at specific organs. The lungs and the liver seem to be prime targets.
They really are. They show the classic changes. Let's start with the lungs, pulmonary congestion.
This is usually from left-sided heart failure, right?
Exactly. The left ventricle pumps blood out to the body. If it fails, it can't keep up with the blood returning from the lungs via the pulmonary veins.
So the pressure backs up into the lungs.
Immediately.
Right.
Right back into the pulmonary capillary network.
What does that look like acutely? Like if it happens suddenly?
In acute pulmonary congestion, the changes are fast and dramatic. Microscopically, you see the alveolar capillaries, the tiny vessels in the air sac walls, become visibly engorged, just swollen with backed up blood.
And the pressure forces fluid out.
Yes. You get alveolar septal edema. The walls between the air sacs swell up with fluid. And critically, you often see focal intraalveolar hemorrhage.
Bleeding into the air sacs themselves.
Yes, because those delicate capillaries rupture under the pressure. This acute fluid leakage is what causes clinical pulmonary edema, that feeling of drowning, a real medical emergency.
Okay, that's acute. But what about long-term? Chronic pulmonary congestion, like in someone with heart failure for years.
That's where the really distinctive permanent changes happen. The chronic hypoxia and the constant stress of high pressure fundamentally alter the lung structure.
How so?
Those alveolar septa, the thin walls vital for gas exchange, they become significantly thickened and fibrotic, scarred, essentially.
Making the lungs stiffer.
Much stiffer, less compliant. And that thicker barrier between air and blood makes it much harder for oxygen to diffuse across, leads to chronic shortness of breath.
And this is where those special macrophages show up again.
This is their classic location, the centerpiece of chronic pulmonary congestion. Remember the hemosiderin-laden macrophages?
From the ruptured capillaries.
Exactly. Because of the continuous low-level capillary rupture, small amounts of blood are constantly leaking into the alveoli. Macrophages are always busy cleaning it up, becoming absolutely loaded with that iron pigment, hemosiderin.
And they have a special name here.
They do. They are so characteristic of this condition, they're often called heart failure cells.
Heart failure cells. Wow.
Finding these cells, these iron-stuffed macrophages, in a lung biopsy, or sometimes even coughed up in sputum,
Yeah.
it's powerful microscopic proof. It confirms the patient has suffered from chronic pulmonary venous hypertension and the overwhelming cause of that.
Yeah.
Long-standing failure of the left side of the heart. They're like the lung's permanent iron stain record of that hemodynamic stress.
Okay. Fascinating. Now let's switch organs. The liver, hepatic congestion. This is usually from right-sided heart failure.
Generally, yes. The right side of the heart pumps blood to the lungs. If it fails, blood backs up from the systemic circulation through the big veins like the vena cava and directly into the liver via the hepatic vein.
And the liver's structure makes it particularly vulnerable, you mentioned.
It does. Unlike the lung's more diffuse structure, The liver is organized into these repeating units called lobules, often pictured as hexagons.
Right.
Blood flows into the lobule from the edges, the portal areas, and drains inward towards the central vein located, well, in the center of the lobule.
So the flow is from periphery to center.
Correct. And that specific flow pattern is key to understanding congestion damage here. It makes the center of the lobule very susceptible to backup problems.
Okay, so in acute hepatic congestion, what happens first?
Acutely, the central vein itself and the sinusoids, the specialized capillaries leading to it, become visibly distended, swollen with blood.
And given that flow pattern, from edge to center, which part of the lobule suffers most when things back up?
Ah, that's the critical point. The central lobular area, the region immediately surrounding the central vein.
That's the end of the line for oxygen delivery.
Exactly. It's physiologically the last place to get fresh oxygenated blood. We call this zone 3 of the hepatic sinus. So when pressure backs up and flow slows down,
Those cells die first.
they are the first to suffer from lack of oxygen. They undergo ischemic necrosis, cell death due to hypoxia right there in the center of the lobule.
While the cells nearer the edge, the periphery, might survive.
They might. The periportal hepatocytes, those in zone 1 near the incoming oxygen supply, might only develop fatty change, or steatosis. It's a sign of metabolic stress, but they often survive the acute hit. It creates this zonal pattern of injury.
Okay, now for the really memorable visual. Chronic passive hepatic congestion. This is where we get the nutmeg liver. Why nutmeg?
It's incredibly descriptive of the gross appearance, what you see with the naked eye. When you slice open a liver that suffered chronic passive congestion, the pattern is quite striking. Those central lobular regions where the cells have died and there's been congestion and maybe some scarring,
Yeah.
they appear distinctly red-brown. Darker because of the trapped blood and the hemosiderin pigment from those microhemorrhages, and they might even look slightly sunken or depressed compared to the rest of the liver due to the loss of hepatocytes.
So dark distressed centers.
Right. And this is sharply contrasted against the surrounding liver tissue further out towards the portal areas. That tissue is often paler, maybe yellowish or tan, sometimes showing that fatty change we mentioned.
So you get this mottled look, dark spots against the lighter background.
Exactly. A mottled speckled pattern of dark red-brown areas, the congested centers, against lighter tan areas, the less affected periphery. And that pattern genuinely looks like the cut surface of a nutmeg spice, hence the name.
Wow, nutmeg liver. That's quite an image. So microscopically, it confirms this zonal damage.
Absolutely. Under the microscope, you see it all laid out. The congestion packed around the central vein, evidence of hemorrhage. Those hemosiderin-laden macrophages are there too, confirming chronic bleeding.
And the dead liver cells?
And variable degrees of hepatocyte dropout and necrosis, specifically in that centralobular zone. Chronic passive congestion literally redraws the map of the liver lobule based on venous pressure and oxygen supply, potentially leading to what's called cardiac cirrhosis scarring driven by heart failure. #tag implications and advancements in understanding chronic effects. So if we pull all this morphology together, the fibrosis in the lungs, the hemosiderin, the nutmeg pattern with centralobular necrosis in the liver, we have to realize these aren't just, interesting descriptions.
No, they represent real damage.
Real, tangible, often irreversible damage,
Right.
all driven by the simple hydraulics of chronic venous backup.
And understanding this detailed pathology has real clinical weight, doesn't it?
Yeah.
It tells a story about the patient's condition over time.
Absolutely. Take those heart failure cells in the lungs again. Finding them isn't just saying, oh, there's been some bleeding.
No, means more.
It confirms chronic pulmonary venous hypertension. It tells you the patient has likely had significant, long-standing left ventricular failure. It validates the chronicity, the severity of the hemodynamic problem. It's a historical record written in iron pigment.
And the nutmeg liver, what does that tell us clinically?
Similarly, that pattern signifies long-term centralobular necrosis. If it progresses, it leads to significant liver dysfunction, what we call cardiac hepatopathy, and potentially even liver failure.
Especially if the cause isn't fixed.
Especially if the underlying cause, usually severe right-sided heart failure, isn't adequately treated, it hammers home the point. Passive congestion isn't just inconvenient fluid buildup, it's an active, ongoing process that destroys organ tissue.
Okay, so we've established this core difference. Active mechanism in hyperemia, passive mechanism in congestion. Let's bring it back to the person learning this. Why is hammering home this active-passive distinction so critical for how you approach a patient?
because it completely dictates your management strategy. Your entire clinical response hinges on it.
How so?
Well, think about hyperemia. It's supply-driven. Usually it's either physiological, like exercise, blushing something, temporary and normal.
Or part of inflammation.
Right, part of a necessary defense or healing process. So the treatment, often minimal. You might treat the underlying inflammation, but you rarely target the hyperemia itself. It often resolves on its own.
Okay, makes sense. But congestion?
Congestion is the alarm bell. It signals a major failure in the plumbing, the drainage system. It demands immediate, often aggressive intervention.
Why the urgency?
Because it points to serious underlying pathology. If it's systemic congestion,
Heart failure.
most likely heart failure, you have to treat the heart failure itself, improve the pump function, reduce the venous pressure systemically.
And if it's localized congestion, like that DVT?
Then the immediate priority is dealing with that obstruction. You need to remove the clot or manage it to prevent two things. First, ischemic damage and necrosis in the tissue distal to the blockage. And second, the potentially catastrophic risk of that clot breaking off and traveling to the lungs, a pulmonary embolism.
So the active-passive distinction isn't just academic. It tells you whether to mostly observe or to act decisively.
Precisely. It moves you from just noticing, hey, there's extra blood here, to critical action aimed at preventing permanent organ damage, scarring, and potentially life-threatening complications.
So hyperemia might need local attention for the cause, like inflammation. But congestion often needs system-wide repair or urgent intervention for the blockage.
You got it. It's the difference between managing a minor traffic detour versus dealing with a collapsed highway bridge. The cause is opposite, and so is the required response. #tag conclusion.
All right, let's quickly recap the key takeaways from our deep dive today on hyperemia and congestion. First, hyperemia. Remember, this is the active one.
Right. Increased arterial inflow. Think exercise, inflammation.
And the tissue turns bright red erythema because of all that fresh, oxygenated blood rushing in.
Yeah.
Usually benign or necessary.
Exactly. Then second, congestion. This is the passive one, the dangerous one.
Caused by blocked venous outflow. Think heart failure or a clot like a DVT.
And because the blood is stagnant, deoxygenated, the tissue turns that dusky blue-red color cyanosis, signaling a drainage failure.
And crucially, chronic congestion causes serious long-term damage.
Definitely. That persistent low oxygen and high pressure lead to ischemic injury, cell death, significant scarring, or fibrosis.
And leaves behind those telltale microscopic clues.
Right. Those hemosiderin-laden macrophages, the heart failure cells in the lungs being the classic example.
And grossly in the liver, that distinctive mottled nutmeg liver pattern. Both signs of severe destructive hemodynamic stress over time.
That sums it up well. Active inflow versus passive backup with very different consequences.
Okay, so here's a final thought to leave you with. We've seen how chronic venous congestion, this passive backup, leads directly to significant scarring fibrosis in organs like the liver and lungs. Essentially, a problem of fluid dynamics causes a fibrotic disease.
The link is clear.
So consider this. How tightly linked is the amount of fibrosis that develops to the actual level and duration of that venous hypertension? Is there a threshold? A point where, even if you manage to lower the pressure somewhat, the tissue has already crossed a point of no return?
That's a critical question in managing chronic conditions like heart failure.
Does that fibrotic process become self-sustaining after a certain amount of time under pressure? So simply restoring flow or partially restoring it might not be enough to halt the progression to irreversible organ scarring.
Preventing that transition, that point of no return to irreversible fibrosis, is really a central challenge.
Something for you to mull over. How much does the duration of the backup dictate the prominence of the damage? We'll leave you with that thought until our next deep dive.